Health in Sudan, Wikipedia audio. Sudan is still one of the largest countries in Africa even after the split of the northern and southern parts. It is one of the most densely populated countries in the region and is home to over 37.9 million people. With this rise in population and bearing in mind the political issues that have plagued the country with war and hostility for the last 25 years, healthcare has become an afterthought and basically lost in the midst of what the government might believe to be more pressing matters. Sudan still has a long way to go to achieve its Millennium Developmental Goals and to establish an adequate and efficient healthcare system that benefits every individual in the country. History of the medical research and providing professional medical healthcare in Sudan could be traced back to 1903, when the Wellcome Research Laboratory was established in Khartoum as a part of the Gordon Memorial College. Situation: Sudan, with an increasingly aging population, faces a double burden of disease with rising rates of communicable and non-communicable diseases. Water is a main cause to each of these. The Sudan Household Survey 2010 showed that 26.8% of children aged 5 to 59 months had diarrhea, while 18.7% were sick due to suspected pneumonia in the 2 weeks before the survey was done. Protein energy malnutrition and micronutrient deficiencies continue to be a major problem among children under 5. With 12.6% and 15.7% suffering from severe wasting and stunting, respectively. The most common micronutrient deficiencies are iodine, iron, and vitamin A. Concerning the MDGs, still 73 out of every 1,000 children born do not live to see their 5th birthday. The maternal mortality ratio per 100,000 live births estimated at 730 deaths per 100,000 live births in 2010. The MDG target for malaria has been achieved, although it remains to be a major health problem. In 2010, malaria led to the death of 23 persons in every 100,000 population. While in total over 1.6 million cases were reported, the annual incidence of new TB cases for 2010 is 119 per 100,000, half of them smear positive. TB case detection rate of 35% is well below the target of 70%, but treatment success rate at 82% is close to the WHO target of 85%. With respect to HIV/AIDS, the epidemic is classified as low among the general population, estimated prevalence rate of 0.24% with concentrated epidemic in 2 states. The socio-economics of Sudan were deteriorating after the separation of South Sudan, while there is still conflict in Darfur, South Kordofan, and Blue Nile states. Sudan's economy has suffered a great deal from this. Firstly, from a fall in oil prices and more recently from the loss of revenue from South Sudan for oil transportation. In addition, there are continuing sanctions and a trade embargo. Due to these occurrences, funds for health have been cut, adding to the fragility of the health sector. In the past, the health financing system in Sudan has undergone several changes, from a tax-based system in the late 1950s to the introduction of user fees along with social solidarity schemes such as the Takaful system. The social health insurance scheme was implemented in 1995, alongside which the private sector grew exponentially, leading to increased out-of-pocket from households in 2006. Free emergency care for the first 24 hours was announced free of charge, and the free finance policy for children under 5 and pregnant women was adopted in 2008. Sudan has also reviewed health system financing using the OASIS approach as a prelude to framing its national strategy for health financing. Also, the country has embarked on developing detailed roadmap for providing universal health coverage to its population. Malaria is one of the most deadly and epidemic diseases that affects Sudan and the African region in general. This is mainly due to the high temperatures and inadequate infrastructure regarding drainage and sewer systems. Stagnant and still water that builds up and is not drained becomes a reservoir and breeding ground for mosquitoes. This leads to their large numbers in the affected area. Still, we have reason to believe that the effect and burden of malaria is somewhat underestimated. In 2007 a study was conducted in Sudan which revealed underreporting of malaria episodes and deaths to the formal health system, with the consequent underestimation of the disease burden. Children less than 5 years of age had the highest mortality rate in Dallas, emphasizing the known effect of malaria on this population group. Females lost more Dallas than males in all age groups, which altered the picture displayed by the incidence rates alone. The epidemiological estimates and Dallas calculations in this study form a basis for comparing interventions that affect mortality and morbidity differently, by comparing the amount of burden averted by them. The Dallas would mark the position of malaria among the rest of the diseases, if compared to Dallas due to other diseases. Uncertainty around the estimates should be considered when using them for decision-making, and further work should quantify this uncertainty to facilitate utilization of the results. More epidemiological studies are required to fill in the gaps revealed in this study and to more accurately determine the effect and burden of the disease. The World Health Organization was notified by the Federal Ministry of Health of Sudan of an outbreak of yellow fever in 2012 which affected 5 states in Darfur. The yellow fever outbreak resulted in 847 suspected cases including 171 deaths. To reduce the spread of yellow fever, the World Health Organization worked with the Federal Ministry of Health in Sudan on a vaccination campaign that halted the outbreak. Nodding disease or nodding syndrome is a new, little-known disease which emerged in Sudan in the 1980s. It is a fatal, mentally and physically disabling disease that only affects young children. It is currently restricted to a small region of southern Sudan. HIV/AIDS estimates as of 2014. Sudan is bordered by 7 countries in which HIV/AIDS is highly prevalent, therefore Sudan is susceptible to an increase in HIV/AIDS prevalence. In 1986, the first case of HIV and AIDS in Sudan was reported. Sudan's HIV epidemiological situation is currently classified as a low epidemic, as of July 2011. The main mode of transmission worldwide is through heterosexual contact, which is no different in Sudan. However, transmission varies in different countries. In the United States, as of 2009, men who had sex with men was the main mode of transmission, accounting for 64% of all new cases. In Sudan, however, heterosexual transmission accounted for 97% of HIV-positive cases. History of healthcare in Sudan. As of January 5, 2011, the adult prevalence in Sudan was found to be 0.4%, an estimated 260,000 were living with HIV and there were 12,000 HIV-related annual deaths. A population-based study was conducted in 2002 which estimated the seroprevalence to be 1.6%. According to recent studies, the HIV and AIDS prevalence in Sudan among blood donors has increased from 0.15% in 1993 to 1.4% in 2000. Sudan is considered to be a country with an intermediate HIV and AIDS prevalence by the World Health Organization. HIV/AIDS related services have been introduced in all the states of Sudan. Free services have been provided across the country, which have significantly improved the life of people living with HIV. Little data is found in literature about the oral health in Sudan before the 1960s. Studies conducted after that showed different results because they were carried out in different populations and clinical settings. About 772 dentists are practicing in Sudan in 2008. Dental services are included in insurance schemes with the exception of dentures, orthodontic treatments, and plastic surgery. The Decay-Missing-Filled Index are indicators used to determine the status of dental caries. The table below is from a 1993 report reporting on such data. Percent affected, DMF, 4-5 years old. Age. Recent health situation. Vital statistics. Percent affected. Health policies, systems, and financing. Communicable diseases. Malaria. Yellow fever. Nodding disease. DMFT. D. M. HIV/AIDS. F. Year. 4-5 years *. 42. 1.68. 1.62. 0.03. Transmission. 0.03. 1990. Statistics. A total of 275 school children in kindergartens from Khartoum were studied. Percent affected, DMFT, different age groups, Khartoum State. Treatment, care, and support. Non-communicable diseases. Levels and trends in under 5 and infant mortality. Age group. DMFT. D. M. F. Year. 12 years. 0.5. 0.4. 0.03. 0.03. 2007-08. 16-24 years. 4.2. 2.9. 1.2. 0.1. 2009-10. 25-34 years. 5.5. 3.3. 1.9. 0.3. 2009-10. 35-44 years. 8.7. 4.1. 4.2. 0.3. 2009-10. 45-54 years. 9.8. 4. 5.5. 0.2. 2009-10. 55-64 years. 12.2. Maternal health. 3.9. 8. 0.3. 2009-10. 65-74 years. Oral health in Sudan. 14.4. 3. Dental caries. 11.3. 0.2. Decay missing filled index. Periodontal disease. 2009-10. 75 plus years. 15. Cleft lip and palate. 3.3. 11.8. 0. 2009-10. Percent having highest score, different age groups. Age group. Number of dentate. 0. 1. 2. 3. 4. Year. No disease. Bleeding on probing. Calculus. PD 4-5 mm. PD 6+ mm. 15 years. 160. 45. 23. 33. 0. 0. 1990. 15-19 years. 126. 0. 1. 0. 95. 4. 1991. 35-44 years. 101. 0. 0. 3. 71. 26. 1991. This malformation showed a prevalence of 0.9 per 1,000 in Sudan. More girls are affected than boys, with a male-female ratio of 3:10.